It's a great privilege to be a part of the INASL. I'm delighted, and I must thank Dr. Ajay D'Souza and his team for his excellent organization of this conference. Now, my the first talk is going to be endohepatology. Endohepatology is a new kid in the block, and it is a new arrival in the horizon. And now we have seen the progress of endohepatology. We have Dr. Ajay Kumar with us, who is an eminent endoscopist of our country. He is a fitting person to trace what was the, before the term endohepatology, what was there in the past, what was happening later on, and what is the future of endohepatology. Then Dr. Ajay Kumar, over to you.
Thank you, Dr. Chandrasekhar. Friends are meant for that, to praise each other's, and that's the privilege of having you as a friend. And thanks, Ajay, for organizing such a wonderful conference and giving this opportunity to be amongst you all. The topic assigned is the journey of endohepatology, past, present, and future. Well, endohepatology is a very loose entity terminology wise. Some people will like to talk about the new technology contributing to the development of endohepatology, to looking at biopsies and portal pressure measurements and all. Some people like to include the entire spectrum of hepatobiliary endoscopy into that whole thing. When you talk about the past, as a student, the only thing that I can recollect, the past was only the management of varices, whether esophageal or fundal, and fundal, of course, with the use of endoscopic glue. I'm not talking about the modifications of that we'll talk later. So, so we never considered as a separate topic per se. But now, actually, this is what Jant had written an article with integration of various diagnostic as well as therapeutic strategies in the practice of hepatology using advanced endoscopic techniques. So the key word that is added here is the advanced endoscopic techniques. And if I have to look at that technique, endoscopic ultrasound is the cornerstone which has changed this outlook of going beyond the lumen of the intestine, the lumen of the esophagus and stomach, and addressing the issues in hepatology. The endohepatology current, so I said past was only varices. The current, some people will like to assess liver fibrosis by the US elastography. But the key areas which I touch upon, some of the two of them, that is a liver biopsy, measurement of portal hypertension in more details, and so is a glue and coil for varices. And then there are advancements that some people, basically this is where we come in direct, endohepatology is something which comes in direct competition with intervention radiology, where you do all these measures, and we need more evidence to show which one is better and how it's better. And of course, a few words about what is the future which is possible. If you look at the liver biopsy, which is the first modality which has been used as a terminology of endohepatology, we all know that traditionally routes for liver biopsy are percutaneous, transjugular. And now we talk about US guided. The percutaneous, we all know, is a simple, inexpensive, though with passage of time, it has gone totally to the IR people, because all of us now opt for a ultrasound guided liver biopsy and not a blind biopsy. And of course, it does have its drawbacks. It still can have some hemorrhagic issues, pain, and especially in the children and the pregnant ladies overlap with ascites, it's always a challenge to do that. Transjugular, the key advantage is that it can be performed with coagulopathy. And I think that's the key advantage. And also, the second major advantage is it allows portal pressure measurement. But the drawbacks are that you need, of course, you need expertise for that, and you have a radiation exposure, and it adds to the expenses. The whole catheters and everything does cause increase the expenses. Now let's look at where do we stand in US guided. It has come a long way from, say, almost 20 years back when the first case was reported. And now what has been shown that it is a safe procedure. It's a real time done with the use of Doppler so that you can get a long, smooth, vessel free approach. So the chances of hemorrhage are much less likely. And complication rates, some people will say, are comparable to percutaneous and transjugular. Some people say the hemorrhage chances are less. But the main issue is the pain factor, which is associated with the percutaneous, will not be there. And there is no radiation involved, as in transjugular. It is advantages are clinical efficacy, of course, is comparable. When you look at the liver biopsy efficacy, it is that how much of complete portal tracts and what is the length of the biopsy. It is comparable, and the concurrent endoscopic and US you can do at the same time assess the varices, and if you have some other reason to assess on endoscopic ultrasound, you can do in the same sitting. And thirdly, you can take the biopsies from the bilobar where it is indicated. Mostly with the percutaneous, you will taking the right lobe biopsies. Here you can address that, and some people believe that in a MSLD it may be of relevance. Patient experience is better. It's done under sedation, of course, minimal patient discomfort. But multiple procedures like banding ligation, glue injection, or anything, you can do all that in the same sitting. And sedation, and also small children, where it's a very sometimes can be very scary for the children psychologically. You are sedating them, you can do that. Of course, some people believe, Jonathan, his article is written that the benefits to your department, I will not get into that because that's a point of contention. Because whenever we look at these procedures assessment, we are looking at benefit to the patient rather than to the department. So of course, there is a technical thing. I realized after making this that there is a talk after me on the technique of the biopsy. I will just sum up in one slide. That is a 19 gauge end cutting FNB needle is the one which gets you the right amount of liver biopsy piece. Wet suction technique with heparin is the preferred method. You have two passes with three actuations. In the single puncture, you do a multiple passes. And when indicated, do bilobar. Of course, there is some word about hydrostatic. I'm not going to that because the next speaker will be talking on that. So the tissue obtained is almost similar as to percutaneous, and 2 to 3 centimeters is like the ASLD mentions, 2 to 3 centimeter length and more than 11 complete portal tracts. And so that's something which you get with this biopsies. And there is a good data available, and it has shown that US LB gives you almost similar portal tracts as a percutaneous biopsy. And as I mentioned earlier, the pain and bleeding can be slightly more with the percutaneous as compared to the US approach. Now, the second, after talking about the liver biopsy, let's look at the measurement of portal hypertension. How do we measure that, and is it important? Today, what we are doing, HVPG is the standard of care when you were to assess the portal pressure measurements. And we all know, this audience, august audience knows how do you measure that, wedged hepatic and free difference. And we all know, just a slide showing the different, the way you do that. But this is something like which we all know. This question was put by Deka in the yesterday quiz competition also, that how much pressures are relevant. That is more than 10 or more than 12, you talk about compensated or significant, clinically significant or significant portal hypertension. I'm not going to that. But why is there any need for an alternative to it? The need is it's an indirect measurement. You are not taking direct pressures. So there is in a pre-sinusoidal portal hypertension, it is fallacious, it's not useful. And of course, you are using radiation in that. So this is the first animal model when it's Lai et al. Showed in 2004 that you can puncture through the US guided, you can puncture, portal vein is close to both the stomach and the duodenum, and so you can puncture it and take the direct pressures. The problem was the availability of a device which could check on the spot, and then this device came, and this is a Sandeep showing in sorry. I hope this works. It's a nice video to show the pressures. Okay, it's not working. And anyhow, this is a device that you attach to the catheter, and you can measure the pressure straight away. And this is the publication on GI endoscopy 2017. So this is a well can likely to have an impact in clinical practice, because we all understand that clinical significant portal hypertension you assess by checking the pressures, and it could be with more evidence. I'm not saying this is the standard of care today, but with more evidence, more expertise, this could be the next thing. It could replace hepatic venous pressure, HVPG, and it may have a better role in clinical practice. Then look at the varices. Now, we all know that since the first report by Professor Nip Sohendra of a obliteration of the fundal varices by the glue, and so that's, my videos are not working. I don't know. It was working on the preview room. Yes. So this is something, when it started, all of us know that fundal varices was a big challenge, and all work came from Professor Nip Sohendra, and glue became, in India it came almost maybe 20, 25 years back, and this has become a standard of, okay, can we go to the next slide from here? Okay. So, but there are complications and there are failures. There are two things, which is that early onset rebleeding, because sometimes you see the varices which are spread all around like a grapes-like thing, and you cannot obliterate each and every varix. And there are complications of almost 7%. So the new development was when you started talking about US-guided glue, coil, or a combination of the two for the fundal gastric varices. Vikram is to give a talk on this particular topic, but I'll say it's a technique, US puncture with embolization of coil with or without cyanoacrylate. Coil, the advantage of adding coil are mainly twofold. One, the risk of only glue is the embolization. But if you use the coil, your amount of glue that you use is less. And secondly, coil also binds it and prevents its migration. So that's the reason the possible advantage of this is that that is you identify the vessel by the color Doppler. You're actually going directly through the stomach from the transesophageal, and confirm vessel obliteration. You can confirm the obliteration at the same sitting and show that there is a lack of flow post-intervention. It eliminates the need for endoscopic visualization. So if you are an active bleeder, otherwise you can get lost in the fundus of the stomach, and that may not happen here. You can avoid that. And you can even target the deeper vessels like collaterals through the US guidance. And this is just a diagrammatic view that first you inject the coil and then do glue, or other vice versa. This is the landmark paper, Professor Binmoller's paper, and I will just touch upon this, focus on this, that 66 in the technical success of 150, which he could follow almost 66% he showed. All the patients that he showed, that they all had a obliteration of the gastric varices, almost 93%. It's only 7% they were not obliterated. They could retreat as well in one, or you go for a intervention radiology splenic embolization. Now, this technique comes in also direct competition with the IR technique of BRTO, and which is also a very good technique. We do follow in a number of patients, but this is one which is from there with the least number of adverse events it has come. And people have used it as a prophylaxis, which is a point of controversy, as a primary prophylaxis. We don't use it as a routine, but then people have used it and shown the effectiveness. This is a wonderful video which I got from Nagi. Actually, Nagi was supposed to deliver this talk before this. So I had the advantage that I could, but this I think worth going to that is a huge fundal varix, and you look at, you put two coils in there, not one. It adds to the expenses, but because it is a very big one, and after putting coil, then you give glue injection, and then document that there is no flow after the injection of these two. And that's the endoscopic view immediately after completing the procedure. And that's after 4 months after the procedure. And then you see the no residual flow on US. And 9 months follow-up, it's almost totally gone. So this is a wonderful technique. The challenge here is, should you use at the first line in everybody, or when to use that? I think the Vikram will be answering those questions in his talk. And we've come a long way, and I think this is a part of endohepatology, where we talked about the diagnostic modality, and this is a therapeutic modality as a part of endohepatology. And this is again, Jan Samanta's article on an international multi-center propensity matched analysis, which has shown that using coil plus glue is safe with better efficacy and low rebleeding rates on follow-up. This thing. Uh, a word about single slide. This is, again, the video is not working. This is Greg Haber, when he was there for the Endocon in Hyderabad, he demonstrated this live procedure that you can puncture the HCC and offer whatever the radiologist is offering, percutaneous microwave ablation, you can do with this procedure. And Vikram was actually there with Greg Haber to show this procedure. So now, the US over enthusiastic or enthusiastic people are going ahead and almost trying to replace the IR people totally, that even tips can be done through that. Now, I come to the last part where treat NASH. Now, this is this existing, now we can take it as a part of endohepatology, because we know insulin resistance is the root cause of metabolic disease, and the duodenum is the whole nerve center of the incretin metabolism, and people have shown that the number of incretin cells in euglycemia and type 2 diabetes are different, and people are today, if you can burn the, regenerate the duodenal mucosa, burn it and regenerate it, then probably it will be answer to the diabetes, because the nerve center is not in the pancreas, but in the duodenum. So endoluminal approach to the duodenum may decrease insulin resistance. And that's from where this concept came. And this is a very wonderful study done in a type 2 severely obese diabetes in Roux-en-Y bypass, and they've shown that if you do that, you achieve normoglycemia. In the same thing, they put a gastrostomy tube over 2 tubes and fed through that, and then they showed that there is a hyperglycemia when you start the feeding. And once you and then when you start the normal oral feeding, it reverses to euglycemia. That documenting is adding to the fact that duodenum is the place if you can avoid the stimulation. Duodenal nutrient passage strongly influences insulin sensitivity independent of weight change. And so this is a so this is a diagrammatic presentation of when the first presentation came, this concept was shown in 2019, that you can, duodenal mucosa can be burned by the heat. There's a heat energy that they used. And once you do that, and they've shown that the diabetes, there's a fall in the HbA1c and the requirement of the medicines to treat diabetes. And this is the, I'm sorry, I think, okay, time is running up. We'll skip the video. And then, so this is basically pre-procedure duodenum. You lift the duodenal mucosa to prevent the deeper tissue injury when you are applying energy. Then you ablate the duodenum, and then there is a 3-month follow-up that the mucosa regenerates. And so that is one part. And then second part is that it shows that 12 months post single DMR procedure, glycemic improvement was sustained, HbA1c did come down, and the requirement of insulin or the antidiabetic medicine goes down. And that's the one part. And now the second part, which has been shown, that you check the MSLD parameters and you look at the ALT, AST, and FIB4, and all these have shown improvement. And of course, now there are other modalities available more than heat, because heat was causing some concern that it may cause duodenal stenosis later on. And the combines a laser and endoscopic recellularization by electroporotherapy. And there's a video, so I'll skip that because otherwise time will go. And it has shown that the full length duodenal resurfacing, and it occurs with that. And this is actually we can show this video. I think we have time for that. No, it's okay. The time is run. So the point to say is that following this resurfacing, the duodenal mucosa regenerates, and it takes care of the diabetes, it takes care of the MSLD. So I will tend to include that. It has shown that the fat levels, liver fat percentage comes down, and it is a insulin requirement comes down. And these are nice. So to sum up my things, that you can select your procedure depending upon whether it's a lean NASH or it's a obese NASH. You can go for, you have other endoscopic procedures, and now you have the newer drugs with the GLP-1 analogs and GIP combinations, and there's a huge noise about that. And of course, you have a lean NASH, that where you can offer endoscopic DMR, you can take care of both aspects, diabetes as well as NASH. And maybe the treatment of diabetes will shift from endocrinologists to the hepatologists or endohepatologists, and the future is bright for them. And so, friends, I conclude by saying that endohepatology has shown it's feasible. There are certain procedures, a lot of procedures need to be validated, it is safe, and it is efficacious, but we need to produce more evidence for more number of procedures. Of course, liver biopsy probably has come to, if you can cut down the cost, probably it can be the actual solution. So endohepatology is a one-stop solution for a lot of these problems. Thank you very much.
Thank you, Ajay, for a wonderful exposition of what is the past, present, and future of endohepatology. Can you join us here? And the talk is open for discussion. My co-chair, Dr. Professor Sinha, will take up the questions.
So we can have some comments and queries from the house.
To set the ball rolling,
Dr. Arka.
Sir, I just wanted to say about the US PPG. So, sir talked about the proprietary manometer that is used for measuring the proprietary manometer that's used for measuring the PPG. That is not available in India, but the PPG can be, the setup can be modified such that we can measure it with a standard display monitor with the CVP parameter, the CVP pressure module. And we have validated the setup and with the ex vivo formulas and things that's been presented in INASL. And I think Dr. Narendra will be discussing further about it. But I just wanted to opine that this might be one important field, because now the indications for beta blockers is becoming any patient with CSPH. So therein, endoscopy does become a one-stop shop, because if the patient has varices, the patient has CSPH, no varices, you can just put in a needle, look at the PPG, and then decide whether you want to give him beta blockers. Thank you.
I think that's we need to develop those modalities. There's no debate about that. But more important than that is to produce more evidence that what is used. And the only thing is that I know Jan Samantha in his article had written the word of stop shop. I knowingly changed it into one stop solution rather than making it a shop. That's what
Thank you, sir, for that excellent lecture. I have one question regarding duodenal mucosal resection. Do you have any data on subsequent complications like perforation of the duodenal mucosa and subsequent stricture formation?
There were some reports when the first study came, and that's the reason they shifted from heat ablation to the different laser and all those things they're trying. And it's still not come into day-to-day clinical practice. So I think technology is getting improved and is being tested. 2023, you had a lot of abstracts on that in DDW, and I think we need definitely more data and more sophistication techniques. The concept is proved, concept is good, and it's a question is. And interestingly, when I gave my first talk on ISG Daily on the metabolic endoscopy, I showed that time only the first trial had come. Pankaj J. Pasricha was sitting in the audience. Actually, what he told me that he's already registered a trial on an oral pill which will go and coat the duodenal mucosa and do the same action that what you're doing so that food can bypass the duodenum because it is coated by something which it does not allow the stimulation of those other chemicals. I've not heard more about that. This has been almost more than 7 years, but people are working on that. Conceptually, this is a strong concept. But the question is how to take care of what is the best technology that has to be done. And if you get a pill for that, so you have a pill for the diabetes here, you have a pill for the weight, I think you have won the battle.
Excellent talk, sir. Just one point where you had mentioned it in passing in the talk also, is that the heterogeneity stems out about combining data for primary prophylaxis and those who have bled. Event rates of bleeding in those who are being primarily prophylaxed, which is not a standard of care yet, and mixing them up with those who have already had a bleeding and prevention of next rebleed, most of the data, even that propensity math study, clubs those patients together. And we know through the natural history of gastric varices that the event rates of primary bleeds are very, very variable. So I think that is one gray zone which we need to address. We need large multicentric prospective studies to actually look at a parallel arm with or without bleed, and then possibly make algorithms as to those with primary, which would actually need undergoing a primary prophylaxis.
I think I can't agree more with you. What you have said, what I understand, you're talking about primary prophylaxis, and I already mentioned in my presentation that we don't do the primary prophylaxis unless they're actually very scary looking on this thing. And I'm also convinced that yes, you need more data and you need a better study. Dr. Acharya is sitting here. He'll be able to tell us that whether there's any work being done on that area or not. Or to Acharya, Dr. Chawla are here. So but yes, that's one area which we need. I think Vikram is having a presentation on that, and he will cover that.
Hi,
Yes,
I have a comment. This is Kalyan from Cleveland Clinic. So we have the DMR study that has been approved as part of the
Can you come on
trial.
the first? I'm sorry. Can you come on the first mic? I can't hear clearly.
This is Kalyan from Cleveland Clinic. So we have the DMR study that's approved in our center for almost last 5 years. So like you said, the biggest problem had been COVID pandemic and then subsequently these GLP-1s that have been approved. So we've been trying to redo the amendments about who can be included, whether the GLP-1 should be included, whether the GLP-1 should be excluded, SGLT. So we've been trying to get a good control group in order to actually see efficacy or superiority of the DMR trial. And to answer your question, the DMR complication rate has been very less. And because you raise the mucosa and you actually do an RFA, it's actually a superficial burn where you actually get all the villi blunted. So you get a acquired malabsorption type of state. There will be some weight loss, but again, all small bowel therapies are designed to address the metabolic parameters. All the gastric bariatric
Can you be a
are
little
for
brief
weight
in your
loss.
question to the, so that?
No, I had a comment about
Comment.
the questions about the DMR.
Okay, you want
Thank
to
you.
reply to the comment or? Okay, now along with me, Dr. Sinha and Dr. Umesh Deth, we all join in thanking Dr. Ajay and the organizers, Dr. Ajay D'Souza and his team for this wonderful conference and for giving this opportunity. Thank you very much.